third talk. So again, it is my great pleasure to invite Dr. Professor Mehmet Zileli from Turkey. Um, Professor Zileli is currently the chairperson of the WFNS Education and Training Committee, where we work together very hard recently. So I'm very happy to collaborate this webinar with the WFNS and the JNS. So briefly introduce his career, and Professor Zileli had been the professor of neurosurgery in Ege University in Turkey for a very long time. During this period, he was the president of Turkish Neurosurgical Society for 3 years, and also chairman of WFNS Spine Committee for several years. So today, Professor Zeli's topic is about the update on management of primary and recurrent lumbar disc herniation. So I'm very excited to join your talk. So Professor Zeli, would you start your lecture?
Thank you. Thanks a lot for nice introduction. This is my presentation. Yes. Can you see my presentation?
Perfectly.
Okay. I will try to summarize the WFNS Spine Committee recommendations on lumbar disc herniations. Actually, those recommendations are already in the website of Spine Committee. This is the website, wfns/spine.org, and you'll see many other recommendations as well, like cervical spondylotic myelopathy, lumbar spinal stenosis, trauma, and others. And we have produced 5 papers, which was already published in World Neurosurgery X in this year. They are open access, and you can easily find those papers in the literature. If you look at the epidemiology and prevention, we can tell that the incidence, lifetime incidence of disc herniation, lumbar disc herniation, is about 30%, and symptomatic disc herniation risk is 1 to 3%. And of these, 60 to 90% resolve spontaneously. So from the beginning of my sentences, it is quite confusing, because this disease may heal spontaneously and may be seen easily without any symptoms. Risk factors may be genetic and environmental factors, strenuous activities, weight lifting something, and smoking. These are main risk factors. And we know that radicular pain having specific radiation in one or both legs is usually associated with disc herniation. Pain history is very important, and pain should be assessed with the visual or numeric analog scale and Oswest's disability index. And essential diagnostic tests, if there are certain clinical criteria like straight leg raising test positivity, cross LASIK sign, the decrease in the muscle strength present. There are some other tests like lumbar discography. It is now a historical thing, and there is no evidence for lumbar discography in the diagnosis of discogenic pain. However, facet joint syndrome may be diagnosed with the lumbar facet joint blocks. If you look at the radiology, there are many terms, as you know, bulging disc, protrusion, extrusion, and sequestration. I will not give details of them, but the recent MR terminology, like contained disc herniation or non-contained disc herniations, are a variation of the previous terminology. There are also some other terms from MR, hyperintense zone and modic changes. Modic changes depict the end plate changes of the level. In case of symptoms consistent for lumbar disc herniation, if the symptoms persist 6 to 12 weeks, then you can ask for a radiologic assessment. However, if there is a significant motor deficit and or sphincter dysfunction, we must immediately ask for radiologic investigation. MRI is the gold standard. If there is problems with MRI for the patient, then you can make a CT scan or CT myelography. In the past, we used to do many plain X-rays, but today we know that there are some certain conditions that we can ask plain X-rays. Otherwise, there is no place of them in the diagnosis. As I mentioned before, spontaneous LDH resorption is around 2 out of 3 cases of the cases. Conservative treatment is recommended for patients without a neurologic deficits. What is the conservative treatment? It is somewhat bed rest and non-steroid anti-inflammatory drugs. Bed rest must not be longer than 1 or 2 weeks, and it must not be confined to the bed rest all day long. If we look at the indications, failure of conservative treatment, severe motor deficits, progressive neurologic impairment, and cauda equina syndrome. These three last points are very uncommon. So we mostly make a surgery if a conservative treatment is failed. Earlier surgery is suggested in case of major motor deficit and is associated with faster recovery and might improve motor outcomes. What about surgical techniques? There are many techniques, as you know: open surgery, microdiscectomy, endoscopic discectomy. However, in the literature, there is insufficient evidence to make a recommendation for or against the choice of specific techniques. Although minimally invasive techniques have short-term advantages like short return to work, short duration of hospital stay, there is insufficient evidence to make a recommendation for or against the choice of surgical procedure, especially in the long term. And if you look at the 6 months or 12 months results, the outcomes are same. What about sequestrectomy or standard microdiscectomy? If we find a significant sequester during surgery, and shall we try to enter the disc space? There are very nice studies that there is no difference in the functional outcomes and complication rates in short and medium term. So you can choose sequestrectomy alone. What about fusion? Fusion is not recommended as a routine treatment following primary disc excision. However, if there is evidence of significant chronic axial back pain, if the patient has severe degenerative changes, or if the patient has instability associated with radiculopathy, then you can consider a fusion surgery. What about the recurrence? Actually, recurrence, even the definition has some problems. The correct definition is a recurrence is a new disc herniation at the same index level and at the same site. If a patient has a left disc herniation and a primary surgery, and after a while he or she has a right disc herniation at the same level, this is not recurrent. So because of that, some papers have described the real recurrent herniations or others. Recurrence at the same level and site as the primary herniation is 101 in this series of Japanese study. From 205 recurrences, almost half are in other levels or other sites. So because of that, recurrence incidence and reoperation incidence may be different. This is again the Japanese study. Reoperation rate may be higher than recurrence rates. What about the risk factors for recurrence? Smoking, persistence of weightlifting after first surgery, and male patients, since they are more active and then carry a higher risk of uh, lifting weights, they may have more recurrences. Obesity is a risk factor in most of the series. However, there are also some studies that high BMI of patient does not increase the recurrence level. What about the systematic reviews and meta-analysis? This is from 2016. They have found that smoking, disc protrusion, and diabetes are risk factors. No correlation with other risk factors they have found. Modic changes are described by a neuroradiologist from United States, Clement Modic, and it describes the end plate changes. If there is end plate edema, Modic type 1 and 2, those patients may be may have a risk for recurrence. So this study from 2020 say that recurrent disc herniation was more common in Modic changes group, and recurrent disc herniation was more common in the hyaline cartilage group. They have looked at the herniated part. If there are hyaline cartilage parts in the pathology, those patients will have in the future more recurrences because the end plates are being disturbed and they are inside the disc herniation end plate parts. Risk factor for recurrence, this study has done a nomogram for that, and they have found that the course of the disease, Firman grade is a type of, is a classification of the disc degeneration. 1, 2, 3, 4, 5 levels of disc degeneration, the blackness of the disc. Modic changes and migration grades are risk factors. What about the disc height, range of motion, and width of L5 vertebral transverse process? These are also risk factors. And another risk factor is the lumbosacral transitional vertebra. Range of motion in that segment is a recurrence group is more range of motion than non-recurrent group. This study is a meta-analysis from 2014 telling that the type of surgery is important, especially minimally invasive discectomies, endoscopic surgeries have higher recurrence rates. This is from 16 trials involving more than 2,000 patients. Although there are some contrary publications, this is generally accepted in the literature that tube-guided surgery and endoscopic discectomy may have higher recurrence rates. For instance, this study from 2017, looking at the standard discectomy with micro discectomy, they have this study conclude micro discectomy has lower recurrence rate, in contrary to the previous one. What about the disk space irrigation? Actually, this is a nice study with very large cohort. They have found that intervertebral disk lavage can reduce the rate of recurrence. This study has looked at the surgeon's experience. If the surgery has done by a consultant or a registrar surgeon, although registered surgeon has 1.2-fold higher risk of recurrence, there was no linear relationship between experience of surgeon and rate of reoperation. I mean, it is statistically not relevant. So what about learning curve? It is also important, especially in tubular microdiscectomy. In the beginning of the series, the surgeons had more recurrences than when they have done more than 100 cases. A decrease in surgical time and recurrent herniations were observed over time. And the rate of recurrence in tubular microdiscectomy in the literature is about 7.1%. What about other surgical factors? The level of lumbar microdiscectomy has not proven to affect recurrence rate. The amount of disc material removed has no relation with the recurrence rate. So if you are thinking psychologically that if I remove too much material, disc material, I will have less recurrence, this is not true. What about the annular repair devices? One of them is Barricade. They have reported 1-year results in a randomized study, and they have found that the recurrence rates is reoperation rates according to the controls, they have lower recurrences, reoperations, and serious adverse events are also lower. But in the long time, the results are not like this, and we cannot tell that annular repairing devices do prevent recurrences of lumbar disc herniation. What about choosing discectomy alone or fusion surgery? This is another discussion. If you want to choose fusion in a recurrence, it will add extra cost, longer operation time, and more complication rates. This is very obvious. In this study, 2016, discectomy and fusion has been found better than discectomy alone with the back pain and JOA scores. However, this 2016 study say that the data suggests that microdiscectomy has lower complication rates and postoperative back pain improvement was greater in the microdiscectomy group than open surgery group. And this study says the complications of fusion surgery is more than discectomy alone, but it's very small difference here. Open discectomy and microdiscectomy complications are quite different. Microdiscectomy has less complications. And this study says discectomy and fusion is better than discectomy alone. And however, this systematic literature review with many publications, there is no superiority of one method over the other. And they say fusion must be considered when spinal instability, deformity, and associated radiculopathy is present. And this study again with saying that comparing the cost analysis, cost utility analysis, and then saying that conservative treatment is less expensive than discectomy and fusion. As the spine committee, we tell that recurrent lumbar disc herniation is a new disc herniation at the same level and site Recurrence incidence is between 3.5, 3.8 to 7.4%. Smoking, younger age, male gender, obesity, diabetes, persistence of weightlifting, modic changes, migration grade, lumbosacral transitional vertebra may be factors to predict recurrent disc herniation. Disc lavage may reduce the rate of recurrence. Experience of surgeon does not reduce the reoperation rates. There is no evidence to conclude that recurrence can be prevented by activity restriction after primary surgery, by weight loss, smoking cessation, and muscle strengthening exercises, although we routinely ask the patient to make those changes, but there is no good study telling this to us. And clinical outcomes after surgery of recurrent disc herniations are inferior to initial surgery. We are having worse outcomes after such surgeries, and fusion should be considered when spine instability, deformity, and back pain more than leg pain is present. And this is our algorithm. If the recurrence is from contralateral side, just discectomy. If it is from ipsilateral side, the disc height is decreased, only sciatic pain and long duration after first surgery, then discectomy alone. However, if there is severe back pain attacks after first surgery, severe modic changes, additional stenosis, disc height is preserved, then fusion may be considered. If it is a second recurrence, fusion must always be considered because of failed two decompressive surgery. I repeat my slides on the website. Again, you can find them in the open access. And I want to invite you all to Istanbul WFNS educational course. It will be 3 days course. First day, spine, second day is cryocerebral, and then hands-on workshops. And that Middle East Spine Congress in Tunisia. Thank you.
Thank you, Professor Zileli, for very comprehensive and educational talk about the lumbar disc herniation. I learned a lot about the basic knowledge. So I think there is one or two questions from the audience. The first one is, what about adjacent segment disease? Does adjacent segment disease affect the pathology of the lumbar disc herniation?
Yeah. Adjacent segment disease, we can consider it if we are making a fusion surgery. It is a complication of fusion surgery. But in the primary disc herniation surgery, it's not an issue for us. What's the other question?
And there is another question about ozone disc nuclear lysis. About this is a very complicated question about. Okay, can you catch it?
Yeah, this must be done not for real disc herniation, but for discogenic pain, actually. I'm not against this. Intradiscal lesions can be done in bulging discs or discogenic pain patients. But if it is a sequestered disc or extruded disc or a significant sciatic pain, radiculopathy, those patients are not good candidates for ozone application.
Okay, thank you. So we have a couple of minutes more. So Dr. Hida, do you have any questions or comment on this topic?
Thank you, Professor Fujimura. Dr. Zileli, thank you for your wonderful and comprehensive lecture. And I think just moving into this present hospital, I have a lot of patients with lumbar disorder, actually. And in that, among them, I think lumbar disc herniation only, maybe conservative treatment just is working. I think 80, 90%. We somehow now drug is so effective. But I think,
Exactly. Yeah.
but but not only lumbar disc herniation only, but plus lumbar stenosis patient plus herniation patient, maybe conservative treatment doesn't work in it. What do you think about it? In
Yes.
that case, we should operate as for them.
Yeah. Actually, although there are not very well designed studies in the literature, since if we are talking about evidence-based medicine, we are also given the evidences from the literature. However, it is also my concern if there is lumbar spine stenosis and disc herniation together, those patients should go more to surgery. Another
Yes.
concern is for the extraforaminal disc herniations. If a patient has an extraforaminal disc herniation with typical neuropathic type of pain on their legs, since those herniations squeeze the spinal ganglia, they must go more to surgery. Otherwise, if you wait for a while, then their neuropathic pain do not resolve totally.
Okay,
These are
thank
two
you.
concerns. Yeah, right.
Okay, so we are almost on time, but Dr. Endo, any short comment or question?
Thank you. Thank you very much, Dr. Zileli, Professor Zileli. Very informative lecture. Then I'm very glad to have this lecture, spine topic, which is actually not so many neurosurgeons in Japan is familiar with the spine surgeries, as you know. So I'm very glad that you selected Professor Fujimura and Professor Kuroda. Japanese Neurosurgical, Society selected spine as one of the first educational seminar lecture, which I really
Exactly.
glad. And
Yeah.
to those neurosurgeons, lumbar disc hernia surgery is something similar to the trigeminal neuralgia surgery. If patient is having pain, severe, then we do the surgery, then take the lesion out, and the patient is happy, smile, and they're crying and thankful to us. So, because of the time, my question is how do you approach the recurring case? I have a recurring case, the lumbar disc hernia, then the data says blah, 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 but, it's very difficult decisions to offer the surgery for those who suffer recurrent pain after the first surgery. Do you have any opinions or comments?
Recurrent pain after surgery or recurrent disc herniation after first?
Recurrent disc herniations. How much do you offer surgical reoperations for those?
Yeah, this must be similar to the primary disc herniation. Actually, you should try again conservative treatment. If it doesn't resolve in for 6 weeks, then you can consider surgery. If it is just a sciatic pain and no back pain at all, and the disc height is decreased, so those patients may go to discectomy alone. However, if the disc height is preserved, very obese patient and with back pain episodes before, and some modic changes additionally, those patients should better go to a fusion surgery. This is a very small summary of my talk.
Yes, I really understand very much. Thank you very much.
So thank you again. Thank you so much for the great talks, and it's time. So I would like to close this session. So Professor Kuroda, so would you make some closing remarks, please? Thank you.
Thank you very much, Professor Fujimura. Now I'm very, very happy because I could really enjoy 3 wonderful lectures about spine surgery, including intramedullary tumor and spinal vascular disease and OPLL, and also lumbar disc herniation. All of our contents are very, very informative, and it will be very, very useful for all of audience, including me. So once again, I would like to thank you all of three speakers. And as I told you before, this is our first trial of international web seminar by Japan Neurosurgical Society and WFNS. And now we are planning to host such a web seminar 3 times or 4 times per year. And so we will be able to come back here with other topics. For example, skull-based surgery and vascular surgery, and also pediatric neurosurgery. So I'm very, very looking forward to seeing all of you once again here. Thank you very much, Professor Zileli, Professor Fujimura, and Professor Hida, and Professor Endo, and also all of audience. Thank you very much.
Thank you.
I thank you all. Thank you. Goodbye.
Yeah.
Wish to see you again.
Bye-bye. Bye-bye.